there is sufficient scientific evidence to causally link tobacco use to almost 20 different types of cancer. And it's not just cancers that you would think, are directly in contact with cigarette smoke. So when we think about the oral cancers of the mouth, the nose, and the lungs, those ones kind of make sense. But it's even been shown to affect cancers throughout the body. So things like cervical cancer, bladder cancer, etc. You can see the list on the screen there. So this graph just shows the incidence of lung cancer correlated with the current smoking rate in Ontario, just to give you an idea of how strongly they're correlated. So you can see across the different LINs, or local health integration networks in Ontario, that the areas that have the highest current smoking rate, which are the areas up in the north, also have the highest incidence of lung cancer. And so you can just see a pretty strong correlation between smoking and lung cancer. Also in Ontario, this is how the regional cancer, the cancer system in Ontario is set up. So Ontario is split into 14 different regional cancer programs, which more or less align with the LINs. And each regional cancer program has a regional cancer center that is located within a host hospital and is responsible for most of the cancer services in that region. And what we see in Ontario is that approximately 20% of all new patients coming to a cancer center in Ontario are current or recent smokers. And so these are people who have been diagnosed with cancer. Approximately 20% of them still smoke cigarettes, and that's the population that we want to focus on when we think about providing an intervention for these patients. And so I'm going to talk a bit about why this is important. So there's still some barriers to addressing tobacco use among cancer patients. I think there's still a lot of myths out there that hopefully after today you won't still believe any of these myths. But so we hear a lot, and these myths exist for both cancer patients and their healthcare providers. But there might be the idea that it's too late to quit smoking for a cancer patient. So, they already have cancer. What's the point of quitting smoking? There's also some myths that maybe it's too stressful for a patient to quit after a cancer diagnosis, or misperceptions that cancer patients won't be receptive to smoking cessation at this time. But we know that these are not true. Most people who smoke do want to quit, and this is the same is true for cancer patients. We also see from healthcare providers that there seems to be a lack of knowledge on the benefits of smoking cessation for cancer patients. We hear that maybe there's a lack of time in a busy clinic, and maybe the idea that cancer centers are meant to treat cancer and not prevent it. But hopefully, with some of the evidence that I'm going to present today, we're trying to spread the message, and healthcare providers will come to realize that quitting smoking is a part of cancer treatment, and that it doesn't take much time to implement a brief intervention. So why should smoking cessation be a priority for cancer patients? What we're seeing today is that there's considerable new evidence emerging on the health benefits of smoking cessation specifically for cancer patients. And in 2014, the U.S. Surgeon General released a report called The Health Consequences of Smoking, 50 Years of Progress. And so when we think back to 1964, when the first sort of landmark report from the Surgeon General called Smoking and Health that really identified the link the first time between smoking and lung cancer. And now 50 years later, in this report, they had an entire chapter that was dedicated to the effects of smoking on cancer patients and survivors. And they reviewed a lot of different evidence and essentially came to the conclusion that quitting smoking does improve the prognosis for cancer patients, and the evidence suggesting that quitting smoking at the time of diagnosis may reduce the risk of dying by 30 to 40%. So it's quite a significant number when you think about the potential benefits of quitting smoking to reduce mortality. In addition, the American Association for Cancer Research put out a policy statement on cigarette smoking and cancer patients. And what they found was mostly more or less in line with the Surgeon General's report, saying that the evidence is clear that tobacco use in cancer patients leads to decreased treatment efficacy and safety. So cancer treatments don't work as well. Decreased survival. So again, the increased mortality rate, both from cancer but also from all causes. Decreased quality of life. And a lot of this has to do with the side effects of cancer treatment being worse and their outcomes after treatment. Tobacco use in cancer patients also leads to increase in treatment-related toxicity and side effects, an increase of the risk of cancer recurrence, so that's the cancer coming back, and finally an increased risk of getting another form of cancer. So I'm just going to go over a bit more specifics on the different types of cancer treatment and how cigarette smoking can affect these cancer treatments. So first of all, for chemotherapy, what we know is that chemotherapy drugs work better in people who don't smoke. And so if we can get cancer patients to quit smoking before their treatment, then their treatment will work better. And this is because cigarette smoke has chemicals in it that can impact the metabolism of these systemic chemotherapy drugs. And essentially it reduces the level of these drugs in the patient's blood, and that makes them less effective. Some of the mechanisms of how this happens includes chemicals in cigarette smoke that can induce hepatic enzymes, and that increases drug clearance, so the drugs are going to leave your body faster and be less effective. In addition, smoking can induce an inflammatory response in your body that can induce drug binding, so something that binds to the chemical and makes it not work as well in your body. So essentially, what this means is that people who smoke may actually require a higher dose of chemotherapy drugs to reach the levels needed to be as effective as in people who don't smoke. And when we think about the cost of cancer treatment, that can also have quite a big effect on the cost. Secondly, for radiation therapy, so we see some similar patterns. So radiation therapy works better if the level of oxygen in the body is normal. And so what we know about people who smoke is that their level of oxygen in their blood drops, and that makes it much harder for radiation to do its job properly. We see that current smoking can increase the acute toxicity of radiation, and that also has an impact on side effects. People who continue to smoke during radiation treatment have a significantly lower rate of complete response and 2-year survival. And I've just included an example here of one study, a study of radiation treatment for head and neck cancer that showed the rate of complete response and the rate of survival. So when we look at those numbers, the rate of complete response for smokers, so that means that the cancer was fully treated by the radiation, was 45% versus 74% for non-smokers. And then when they looked at 2-year survival, the rate of survival for smokers was 39% versus 66% for non-smokers. So again, quite significant differences in the outcomes for these cancer patients who continue to smoke during their treatment. Now, when we look at some of the side effects of these cancer treatments, smoking can exacerbate some of the side effects of chemotherapy and radiation, so the side effects are much worse. These include things like immune suppression, weight loss. We know that cigarette smoking can suppress appetite, and so we know that cancer patients experience weight loss as a side effect, and so of their treatment sometimes, and so something that suppresses their appetite is not going to help them in that regard. fatigue. A lot of the oral side effects of chemotherapy are much worse among people who smoke, including things like dry mouth, mucositis, which is a common side effect of radiation, loss of taste, poor voice quality. All of those things are much worse in people who continue to smoke during their treatment. And we also see greater inflammation in their lungs and necrosis of soft tissue and bone tissue death. All of those side effects are worse among people who continue to smoke during their treatment. And finally, with surgery, so we've known for a long time that smoking makes surgical outcomes worse, both in terms of things like wound healing and the rate of infection. Those are all worse in people who continue to smoke. So the same is true for cancer treatment. That quitting or reducing smoking can make surgery safer and help with a quicker recovery. In general, smoking can increase complications from anesthesia, increase the risk of pulmonary complications, and again has a detrimental effect on wound healing. And this is because of things like compromised blood flow, vasoconstriction, that all lead to increased risk of infection. So overall, and just to kind of summarize what the potential health benefits of quitting smoking would be for a cancer patient, from everything that I've just mentioned, is that quitting smoking has the potential to reduce mortality, both from the specific cancer they have, but also when we think about all-cause mortality among people who survive their cancer. Quitting smoking can improve the effectiveness of their cancer treatment, so whether it's chemotherapy or radiation, in a variety of cancer types. So not just cancers that were caused or necessarily related to the smoking, but any cancer that they're trying to fight, the treatment will work better. Quitting smoking could reduce the toxicity that we sometimes see with radiation therapy, could reduce the risk of wound complications and infections after surgery. Quitting smoking would reduce their risk of the cancer coming back or getting a different type of cancer, which is a second primary, and overall improves the quality of life. And so when we think about all of these potential benefits of smoking cessation, there's really no argument for why we should not offer an intervention to these patients. So I'm going to talk a little bit now about what is Cancer Care Ontario doing about this issue and what is kind of our role at a provincial level in terms of addressing smoking cessation. And so Cancer Care Ontario in 2013 launched an initiative called Smoking Cessation in the Regional Cancer Programs. And the vision for this program, which we set out at the beginning, was that by systematically offering a smoking cessation intervention to every ambulatory cancer patient, and so those are new cancer outpatients, the Regional Cancer Program Smoking Cessation Initiative will help to ensure that cancer patients in Ontario achieve the best possible health benefits from their cancer treatment. So just to give a bit of a history of the implementation of this initiative, in 2012, a framework was developed with input from experts in smoking cessation from across the province, and it basically set out kind of laid the groundwork and set the direction for what the regional cancer centers were expected to implement. Essentially, the framework said that all new ambulatory cancer patients are to be screened for their tobacco use, advised on the benefits of quitting specific to their cancer treatment, and finally referred to a smoking cessation service for support in making a quit attempt or support in remaining quit if they had already quit. In 2013, implementation began on the 14 regional cancer centers, and each of them was required by Cancer Care Ontario to designate a smoking cessation champion, and this was a role that was required to essentially roll out the program at their unique cancer center and figure out how to make it work in their setting. And today we have ongoing support from an advisory committee who continues to advise us on the direction of the program, again, with experts from across the province. We have monthly teleconferences with our champions to bring together all of the regions to provide program updates and share practices in terms of what's working well. And then we also do in-person presentations out in the regions to reach oncologists and other healthcare providers to help spread our message in terms of the importance of smoking cessation for cancer patients, just to try and address some of those myths and some of those barriers to offering an intervention. So our program model, which is in the process of being refined. Initially, we based the program on the 5 A's of smoking cessation, and we've recently and are moving in the direction of the 3 A's approach to keep it a bit simpler and address some of the time barriers that we have heard about. So the ask, advise, and act is our 3 A's model. And we are providing some potential scripts that can be used by healthcare providers that you can see on the screen here. So our ask is something simple like, do you smoke cigarettes or have you used other forms of tobacco in the last 6 months? And the reason that we ask about last 6 months use is, again, to kind of catch those people who may have recently quit smoking around the time of their cancer diagnosis. But we know they may be still at high risk of relapse in the first few months after they quit, and so we still want to offer them support to help them remain smoke-free. The second is advise, which should be something specific to their cancer treatment. So saying something like, quitting smoking is one of the best things you can do to help your cancer treatment work better and reduce the chance of side effects. And being smoke-free will also reduce the chance of your cancer coming back or getting another form of cancer. Finally, the ACT, which is essentially providing a referral to the patient, saying something like, I understand that quitting smoking can be hard, but it's easier if you have help. I'm going to refer you to a smoking cessation specialist who can help you make a personalized plan. And just to kind of give some examples of what some of those referral options are, so we really left it up to each region to determine what was the appropriate referral options for their center, just because we know that there are different resources available, different capacity levels at the cancer centers. So the referral could be something to an internal smoking cessation service, so that would be something within the hospital. If they already had a hospital-based quit coach, who had that dedicated role. If there was a pharmacist at the cancer center who could see patients, or sometimes social workers are also trained in smoking cessation and could provide a more intensive intervention. Or the referral could be something external to the hospital, so resources out in the community that could help with a quit attempt. So things like the Smokers Helpline, which has a facilitated fax referral program, the Ottawa model for smoking cessation, which does its own kind of follow-up for that. Many public health units offer quit smoking clinics or stop on the road programs. There's some community pharmacies that offer smoking cessation support that cancer centers have partnered with, as well as some specialized quit smoking clinics that may exist locally. So we really left this piece pretty flexible so that the cancer centers could determine what worked best in their setting. We also collect some data just to help us monitor performance across the province, as well as be able to compare the regions to each other. And so we just have a minimum data set of performance metrics. This data is submitted to Cancer Care Ontario monthly by all of the regions. I'm not going to go through all the data, but just to highlight one of our indicators, which is the first set of bars you can see on this graph, which is our screening rate. So you can see that that has improved quite a bit over the past year. Earlier, I guess at the beginning of this year, we were screening just about 50% of new cancer patients entering the cancer center. And a year later, we're almost up to reaching 70% of all cancer patients across the province who are being screened for their tobacco use. And then we measure how far they go through the next steps of the intervention, so advised and accepting a referral. So we've also developed some patient resources. There was really, I guess, a gap identified in terms of a resource for patients that would specifically address the benefits of quitting smoking for cancer patients. There's a lot of kind of general resources out there, but there really wasn't anything that really spoke to the unique experience of a cancer patient. And so we developed this resource in collaboration with the Canadian Cancer Society, as well as some of our partners in the region. And so it's called The Benefits of Quitting Smoking for People with Cancer. It's just a little brochure, and it goes over some of the treatment benefits based on treatment type, so radiation, chemotherapy, or surgery, has some tips to help you quit. And then on the inside, goes over some ways that they can do it. So talks about different medication options, so things like nicotine replacement therapy, as well as some of the prescription medications, so Chantix and Zyban, and kind of how they could access that. And it also talks about the importance of counseling support, where they could access that, and saying that the combination of medication with counseling could triple their chance of success. So it's really a great resource that is now available in all of the cancer centers. And we've also worked with our Aboriginal Cancer Control Unit at Cancer Care Ontario to adapt this resource for our First Nations, Inuit, and Métis populations. So we can see examples of those cultural adaptations here. We know that a lot of Aboriginal populations have higher smoking rates than the rest of the province, so this is an important resource for us to create. And we have had the First Nations version translated into the OG3 language, which you can see there, and we're also working on an Inuktitut translation for our Inuit populations. Okay, so I am now going to turn things over to my colleagues at the Ottawa Hospital. So next we're going to hear from Robin Morash, who will give us more of a regional perspective in terms of what's going on at one of the cancer centers, which is the Ottawa Hospital Cancer Center. So Robin, I'll turn it over to you.
Thanks very much, Erin, and thanks very much to RNAO for inviting us to participate. Chantal and I are speaking from my office in the Cancer Centre at the Ottawa Hospital, so hopefully you won't get too much in the way of background noise. So what I wanted to talk to you very briefly about is where we went with the CCO experience within the Ottawa Hospital Cancer Centre, how we implemented our new program, and then some of the team roles that are involved. And then Chantal's going to talk about it from a nursing perspective. Can you give me control to advance the slides?
Yes, if you push the space bar, you should be able to go ahead.
Not working, so I'll just use this piece up here. There we go. So the hallmark of cancer care is the quality, and it's really felt that smoking cessation is an essential component of quality cancer care. As said by Dr. Bill Evans, who's a regional lead and actually used to work at the Ottawa Hospital at one point, is the best cancer treatment outcomes will only be achieved if smoking cessation is incorporated into the care of patients. So Erin's really given you the background of why this is, and we believe, as does CCO, that every encounter matters. So we need to talk to our patients and address their smoking status, their desires, and their educational background with regards to smoking cessation on every encounter. Erin's also spoken about the benefits. And really, just to recap, the benefits of quitting smoking while one is a cancer patient is the decreased risk of a second primaries and recurrence of that original cancer, fewer complications from the chemotherapy, the radiation, and a quicker survival and recovery from surgery, and also the improved effectiveness overall. Just a brief description of the Ottawa Hospital Cancer Program itself. So we're attached to the Ottawa Hospital. We have 2 specific sites, and in each site we have an integrated cancer screening program. At the general, we have diagnostic assessment units, cancer assessment, where we have a diagnostic program for lung, colorectal cancer, hepatobiliary, bladder, prostate. And at the Women's Breast Health Center, we see our breast patients. We have 6 cancer clinics that are split between the 2 sites, 2 chemo units between the 2 sites, 3 radiation therapy units again, and 3 inpatient units at the general site. On both campuses, we also have psychosocial oncology and palliative care. Our goal with our smoking cessation program was to start with our outpatient, in our outpatient setting, and dealing with patients on their first visit, so the consult visits. Under the auspices of Cancer Care Ontario, we started in 2013, as Erin has referred to. We started with 1 disease site on 1 clinic, and that was head and neck, because we felt that was the population that we could make the most impact on, knowing already that our lung cancer patients were having their smoking cessation addressed and their smoking status addressed during their diagnostic assessment program. So we follow the Ask, Advise, Refer, or the Ask, Advise, and Act, depending on the nomenclature that you use. And how it worked was a clerk would give the patient in the cancer clinic on their first visit a smoking cessation consult form. This was completed and then given to the nurse on the initial consult visit. The nurse was to review the smoking status with the patient, advise them of the benefits of quitting smoking if they were a smoker, which you've seen Erin had some script there for you, and then refer them to our smoking cessation specialist or our smoking cessation nurse. When we first started, this was a phone contact only, and we learned that that didn't work very well, but it was what we were able to do with the limited funding we had. So our smoking cessation nurse at that time would contact the patient by phone. If she was able to reach the patient, great, she tried twice. If she was unable to reach the patient, then the system didn't work. So she reached the patient by phone, she was able to do a referral and a consultation visit with the patient, and then she had to refer them to their family doctor in order to be able to get a prescription for any of the medication we were going to encourage the patient to take. Our goal was to get them onto nicotine replacement therapy. Now, they don't need a prescription for that, but it did help with the uptake with the patients. At the same time, we were connected with the Ottawa Model for Smoking Cessation that comes from the Ottawa Heart Institute. We had the privilege of working at the same center, so it was easy access to it. And what the Ottawa Model provides is information, education, but integrated voice recognition and follow-up clinics. So if we could get the patient onto medication and encourage them to sign up for the follow-up, then they would be followed through the Ottawa Model team, providing them with ongoing clinic visits where necessary, but primarily it was phone. After we finished with head and neck, we decided we would move ahead with full implementation of all disease sites in all of our clinics on their initial consult visit. What we're missing here is every encounter every time. We had the fortune to find some funds within the Cancer Centre and also with some support for Cancer Care Ontario to hire a temporary full-time smoking cessation nurse, and that's Chantal, who's with me today. This was paramount to our success because the phone visits weren't effective enough to try and maintain the smoking cessation status and to even get patients onto smoking cessation. We also at the same time found some space, so we have a storefront for a smoking cessation office right in the Cancer Centre, so patients will drop in. We were able to set up widespread multidisciplinary education, physicians, nurses, clerical team, psychosocial oncology, and we created documentation tools. Within the Cancer Centre, we use Mosaic. Within our general hospital, we use an electronic health record called Oasis. So you can understand the difficulties we have with 2 different systems, but we were able to get a system into Mosaic that we can document so that there is some communication between our different therapeutic areas. We've now initiated in our treatment area in radiation oncology. Radiation oncology, the therapists, it was always part of their practice to talk to their patients about reducing or quitting smoking when on treatment. We've now formalized that, and we've created a referral mechanism that the therapist can refer to Chantal when they see the patients either on their education teaching or while the patient's on treatment. The other thing we've done is looked at the use of nicotine replacement therapy while the patients are on chemo treatment. We were finding that patients, they have to fast while they're on treatment, not good for them. Patients would want to go outside and smoke during the middle of their treatment. They'd go out and maybe not come back, or they would refuse treatment because of the thought of not being able to smoke for 2, 3, 4, 8 hours, depending on the length of their treatment. So just to recap the process that we have, you'll see we screen, we advise, we refer, and document. In green, we've got counsel and document with the Ottawa model, and that's Chantal's role. So the first two, the blue ones are done by our module clerks. The advising is done by the module nurses. Chantal is the counseling and documentation, and the follow-up comes from the IVR of the Ottawa model, or ad hoc through various external programs, but also Chantal will follow up with her patients, and I'll let her talk to you about that. Our volumes for the Cancer Centre are approximately 7,000 plus new patients a year. And of that, as Erin mentioned, 20% are smokers. So what is working well? To date, the role of nursing is strengthening our practice. Nursing is offering excellent timely advice, and Chantal is able to get patients onto the Ottawa model, onto nicotine replacement, at a greater percentage rate than we would have been able to do by phone or just working within the clinic. We have access to the Ottawa Model for Smoking Cessation program for the ongoing follow-up. We've got ongoing staff education within the modules, and we're working now with radiation therapy, and also getting up into the chemo treatment unit will be our next step. The new position that we have, our smoking cessation for Chantal, her role includes patient referrals, program development, and then ongoing staff education. And we've just found out that we're now able to make that position permanent. We've also got the use of the electronic documentation tools to document the consult, but also an electronic referral form that those that are electronically focused can refer up to Chantal. The last benefit we have within the Champlain-Lynn is our regional resource called MyQuit. 3 or 4 years ago, a group of regional participants got together and formed MyQuit. This included Smokers Helpline, the Ottawa Model, some of our regional health units, and public health. What that gave us is one-stop shopping for patients that are outside the hospital or do not want to belong to the Ottawa Model. Also for family members. It's one phone number they can call, and it's manned by Smokers Helpline. It's also a website where they can go on and self-refer electronically. Again, it gets you to Smokers Helpline. Smokers Helpline then takes a look at the resources across the region and finds one that's suitable to the location or the desires of the patient. Areas where we need to improve. It's all fine to have an ask and advise referral process set in place, but we need to further educate our staff because our screening rates are sitting right now at 58%. The provincial goal with Cancer Care Ontario is 70%. Once we get our patients to Chantal, our referral rates and acceptance and uptake are sitting at 60%, which is the highest in the province, but we're having difficulties with our screening. We have issues with trying to cover 2 campuses with 1 nurse, so Chantal's bouncing back and forth based on patient appointment. We have communication issues, especially related to our electronic health record. We're now auditing cases to look and see where our gaps are so that we can try and increase education. And this also becomes a management issue. The other thing we do not have right now is the ability to determine long-term quit rates for our patients. We can get some of this information from the Ottawa model, but it's not covering all of our patients. New opportunities and initiatives that we're looking at or working on is increasing the information that we put in our patient education videos and chemo teach sessions, or any of our education where we can actually touch the patient. We have medical leadership champions. We're looking at increasing physician engagement. We've had Dr. Bill Evans come and talk, but everybody's response is, I don't have time in my clinical practice. So we're looking at champions and developing a medical directive to provide nicotine replacement therapy to our patients in different places along their journey. We're integrating actually distribution of nicotine replacement therapy itself, and I'm going to let Chantal talk about that. We also have a large population in Ottawa of Inuit patients that come to us from Baffin Island and Iqaluit for treatment. And these patients stay at a residence, and we're trying to provide support there for these patients in conjunction with our Aboriginal nurse navigator, but also to maintain that quitting here so that when they go home, we can try and follow up with them. The last piece we're working on is data, trying to do our audits to figure out exactly where some of our gaps lie. Finally, before I turn it over to Chantal, I just want to put a plug in for the pocket guide that RNAO has created. And this is something you can purchase relatively cheaply from RNAO, and we give, it's very small, fits into a pocket. We give this to every nurse. It really is a nurse's responsibility and part of our practice to try and encourage our patients to live healthy lives, and smoking cessation is one piece of that. So I'm going to turn it over to Chantal now to talk more about the role of the nurse and patients.
Thank you, Robin, and thank you to RNAO for having us today. So I'm going to talk to you a little more about personal experiences, some of my own, what my role is, and what some patient experiences as well. And sorry, next, 25, thank you. There we go. Nope, not 25, Robin. 34. There we go. Okay, back to that one. There we go. So I want to just bring it back to what a patient is experiencing when they have a new diagnosis of cancer. There are a lot of things that are going on. You know, for many of these people, they're hearing the C word cancer for the first time. They're coming to us with a lot of preconceived beliefs, whether it be about their treatment, whether it be about smoking cessation and their own experiences, some financial issues. It costs money to be sick, parking, transportation, time off work. There's fear, what will happen to me? You know, there's a lot of unknowns. And then there's a lot of guilt. There's a lot of stigma around smoking, especially in certain populations. I think especially in the lung cancer and head and neck cancer populations. For many of these patients, I hear often from them that when they tell people that they have a diagnosis, quite often the first question they're asked is, well, do you smoke or are you a smoker? And that's not always the case. Not all smokers develop lung cancer or head and neck cancer, and likewise, not all of those populations have been smokers. So there is a lot of stigma, and there's a lot of guilt for the people who have smoked, you know, that they've perhaps caused this disease themselves, and, you know, why didn't I stop sooner? So for those patients, whoops, I don't want to skip slides. I want to go, there we go. Whoops, okay. So it skipped over on me, but so for those patients, they're coming in and they're hearing, oh, by the way, you need to quit smoking. And for a lot of healthcare professionals, we feel that perhaps that may be too much. Erin touched on this earlier. And I look on that a little bit differently. I think of that as more of a teachable moment. This is a patient who is actually open to receiving some information. And I'm not saying that at this very moment we need to give them all of the information, but I think exactly what Erin said, we need to advise them that this is something that you can do as you leave here today that will help improve your outcome, help make your treatment more effective, and as a result, you're going to have a better experience. So I think that's an important message to give to patients, even at diagnosis, even when they're not quite ready to hear about smoking cessation, quitting perhaps. This is the form that we use at the Ottawa Hospital, and there is a lot of information on this form. So every new consult who's coming in, and if they have 2 consult visits, for example, they may be seeing a medical oncologist and a radiation oncologist on separate days, they're going to fill this form out twice. And that's actually fairly important. So for patients who don't smoke or have not smoked in the last 6 months, it's quite simple. They tick off no on the very first question and they're done. If the patient has used any form of tobacco in the last 6 months, then they go down and complete questions 2 through 8. Questions 2 through 6 are very helpful for me when I'm actually doing the cessation teaching with them to help me decide on dosing of nicotine replacement and whatnot. But I think what's really important for every nurse to look at, especially, is question 7 and question 8. how important is it for you to quit smoking, and how confident are you that you can quit smoking? So those two questions give you a quick snapshot of where that patient is at in terms of information and what your opportunities are to help that patient move along the continuum of cessation. So typically I practice with the Prochaska and De Clemente stages of change, which is pre-contemplation, contemplation through to maintenance. So those two questions really help me to understand better where that patient is on the Prochaska De Clemente stages of change, and helps me to tailor the intervention that I'm going to do with that patient. So there are lots of ways for patients to achieve being smoke-free, and most often we assume it's cessation, and that's, smoking and being smoke-free the next day kind of thing. I don't necessarily believe that's the only way, and in fact, the research is showing that there are other ways that can be as effective. Reducing to quit, which is gradually reducing, whether that be over a period of days, a period of months, a period of years. And quite frequently, you'll have patients coming in who will tell you, if you ask them that, oh, several years ago, I used to smoke twice as much as I smoke now. So those patients are actually in a reducing to quit process. Then there's abstinence. You might get patients who don't smoke during the week or don't smoke while they're at work and only smoke at specified periods of the day. And that's also an important concept. Earlier on, Erin had talked about how radiation therapy can be can be less effective for patients who smoke. And sometimes I see patients who don't want to quit smoking, who want to continue, whether that be at a reduced rate, so reducing, or whether it be that they don't really want to give up at all. And we talk about abstinence, asking them to be smoke-free for 8 hours before their radiation, since we know that smoking reduces the available oxygen in the system, and radiation is at its most effective when there's as much oxygen as possible. But typically what I am teaching with patients is reducing to quit. Because they do come in overwhelmed, I'm seeing them fairly shortly after diagnosis, some of them on the same day that they have been diagnosed. So they'll go from seeing the oncologist and hearing their diagnosis and talking about some treatment right into my office to talk about smoking cessation. And for a lot of these people, smoking has been a coping skill that they've used for most of their lives to help deal with stress. So the thought of becoming smoke-free overnight is probably just too much. You can actually see it in their face. They're quite stressed out. They're seeing me and thinking, now what is she going to tell me? And I almost sometimes think that they think I'm their mom telling them you have to with the finger pointing. So instead, I sit down and talk a little. I change that conversation a little bit and talk about reducing to quit, and we talk about getting quick control of reducing the amount taken in fairly quickly through use of the patch, which is meant more for a long-term control over the course of 24 hours of the nicotine dosing. So what I talk to patients about is getting down to about 5 cigarettes a day or so, and then from there we can work together to look at reducing those rest of the cigarettes at a pace that is more realistic for that patient. So what are the benefits to doing that to the patient, or with the patient, I should say? So there's a lot of, as I mentioned earlier, a lot of stigma and a lot of guilt, and I think in empowering the patient to take control of that, the smoking routines that they have and the smoking, the addiction that they have, that's really important. And often just educating a patient on the fact that this isn't just a habit. They actually have an addiction to nicotine. It's very powerful information. And they can, from there, you can liken it to having an addiction to heroin or cocaine, where you would never send a patient who has a heroin addiction out in the street and say, well, just quit. You need help, you need support, you need a program, you need someone to teach you how to do that. And that's what my role is. I'm trying to be very empathic with patients, non-judgmental. That is so important. If you can approach the smoking as not something that they do, but something that they don't necessarily have control over, and that you're there to help give them back control, then you're going to get a lot more buy-in from the patients. And engaging that patient early and improving their self-efficacy is going to have other beneficial effects. Many of my patients will start an exercise program. They change their diets, they change unhealthy routines in their daily lives, and it just engages them and it activates them, and they get to start treatment with a positive mindset. These are some things that I've heard from patients. You know, I can tell you many stories, but you know, I see a wide variety of patients in my office. Some people have quit for 18 years. Were out at a party, didn't realize that, you know, that the smoking is an addiction, and it has to be treated like an addiction. It is a lifelong addiction. You can be a smoke-free smoker, but you will always be a smoker. And, you know, out at a party, someone handed them a cigarette. They thought, oh, well, what's the difference? I've been smoke-free for 18 years. I'll just have this one. Well, that person within 2 weeks was back to smoking a pack a day. I see people, you know, who have tried countless times and have never made it through an entire day being smoke-free, and we've helped many of these patients to become smoke-free or reduce down to a level that they're comfortable with. Lots of people come in and see me and they've got spouses nagging them. They've probably had symptoms for quite some time, and you know, they're coming to see me and thinking I'm going to nag them as well. But it's really about empowering that patient and teaching them not just to be smoke-free, but how to be smoke-free. And I think that's the big, powerful message for the smoking cessation teams out there who are doing it, is teaching patients how, not just telling them. And my take-home messages: never too late for a patient to stop smoking. I think Erin has been very good at detailing why that is in the case of being diagnosed with cancer. I truly believe there's teachable moments in every encounter, and the challenge as healthcare professionals is for us to find those teachable moments and keep having the conversation. Earlier I showed you the form that we use. I've seen patients go from being 1 out of 5 interested in quitting smoking to 3 days later 5 out of 5 interested in smoking cessation. And if we don't continue to bring that topic up, we may never get to address the fact that the patient has now become, you know, committed to smoking cessation. Cessation is a process. It takes time. There's a behavioral component to it, and you know, in the literature, depending on where you look, it'll tell you that it takes about 90 days to develop a new habit. So it takes time, and to be patient. And if the patient has a relapse and starts smoking again, that doesn't necessarily mean it's a failure. It just means there's another chance for opportunity for education and self-examination. Really important to be non-judgmental and to focus on the positive. You know, often people will come in and chat about, I'm still smoking a quarter of a pack a day. I used to smoke a pack a day, and they feel very much like they're a failure. And I try and turn that around and say, yes, but you've cut out 75% of what you used to smoke. Good for you. That's a fantastic thing that you've done. So I think that's really important, to focus on that positive and not on the negative. Thank you very much.
Okay, thank you so much to Erin, Robin, and Chantal for that great presentation. We're just going to be turning to some of the questions, and just a reminder again, as I'm looking at the time, if we don't get to all your questions, we will share them with all three of the presenters, and then we'll make sure that we respond to the questions. So we're just going to take some of them now. Someone asked for a reference for outcomes and 2-year outcomes in head and neck populations. Erin has agreed to share that article, so we will make sure that you get that reference. Then we had another question that said, in January, the Ministry of Health and Long-Term Care announced free smoking cessation medication quit cards for patients being discharged from the hospital. Are cancer centers part of this program? If so, can you let me know how this is working?
So I can just speak quickly to that. So some of the cancer centers were offered the opportunity to be part of that initiative. Essentially, the quit cards were being handed out, I believe, through the Ottawa model. So any hospital that was already partnered with the Ottawa model had access to these quit cards. I believe they're still just getting that set up and in the process of handing them out. So we don't know yet how it's working or what any of the outcomes are. But the Ottawa hospital does have access to some of those quit cards.
Perfect.
Hi, it's Chantal in Ottawa. Yeah, we do have the quit cards, and just to address the question of how it's working, it's fantastic. to be able to follow up the teaching with a patient with some actual financial help. The quick cards are valued at about $450 each. Integral into the quick card is that they must accept follow-up through the Ottawa model, so there is that follow-up support that we know is so key to patients being successful in the long term. And I've had patients hug me. I've had patients cry when I've handed them that quick card, telling me that they've never had anyone be, so supportive, and the fact that we were giving them something to help them be successful when they left the hospital was really powerful.
Okay, perfect. Thanks for that, Chantal. The second question that we have is, do the findings or results apply to electronic cigarettes or marijuana use?
No, so all of the evidence I presented today was specific to tobacco use, mostly from cigarette smoking and other forms of tobacco, so it does not apply to electronic cigarettes or marijuana. I don't think there's enough evidence yet on those.
Robin or Chantal, did you have anything else to add on that point?
No, thanks. Erin said everything we could.
Okay, perfect. And then the other question that we have is using the 3 A's versus the 4 A's. Can you tell me which is better? And then I'll let Erin speak to the first point, and then we'll address the second part of that question.
The question was about 3 A's versus 5 A's, and we can't really say that one is better than the other. They're both considered a brief intervention. The 5 A's is probably more common and what was recommended, in the U.S. clinical practice guidelines. But what Cancer Care Ontario is starting to move towards the 3 A's was based on feedback from the regional cancer centers, especially because of the time barrier that, healthcare providers think, oh, it's going to take me too much time to do the full 5 A's and offer assistance and all of that kind of thing. And because our program is focused on offering a referral, we moved to the 3 A's to just make it simpler, that they just need to take one action, and that's offering the referral to the patient. So that's why we moved to the 3 A's. I wouldn't say one is better than the other.
Thanks for that, Erin.
And the RNAO guideline.
Yeah, so in the new RNAO BPG, which is going to be released very, very soon, we have taken a different approach in this edition, and we don't specify which one of the A's to use. We have a recommendation on brief intervention, kind of touching on the points that Erin has mentioned. We can't say which one is better than the other as long as there is some sort of brief intervention. But what we do provide in the BPG is a description of each of the 3 A's, 4 A's, and 5 A's. So the last question that we had is Smokers Helpline Canada-wide or just Ontario? So we just quickly looked this up, and Smokers Helpline serves 5 provinces in Canada, and it includes PEI, New Brunswick, Ontario, Manitoba, Saskatchewan, and Yukon.
So just to clarify that every province and territory does have a quit line, just the phone number might be different. And actually there's a number that's listed on all cigarette packages that connects to a national quit line, which will then direct the person to their local or provincial quit line, whatever it might be. So the number that I showed was probably the Ontario number, but every province does have access to a quit line.
Perfect. And if there's no other questions, then this slides will be available to review after the presentation. If there are any further questions? No? Okay. Thank you so much. Just to let everyone know, all webinar participants will be receiving an email from RNAO within the next 24 hours. It's going to include a link to a short evaluation survey for this webinar. And once you've completed this survey, you'll be able to print a certificate of completion. Thank you so much.